My name is Anna Palmer. I'm the CEO and one of the founders of Punchbowl News. We are thrilled to have so many of you joining us in person as well as on the live stream this morning for the Summit Access to Care. We're going to be diving deep into issues around healthcare, particularly when it comes to rural health and hospitals and health systems, and the real world impacts that healthcare has and policies have across the country. A big thank you to the Coalition to Strengthen America's Healthcare for making this summit possible. This morning, we're going to kick off the day with a conversation with Senator Peter Walsh, the Democrat from Vermont. Afterwards, I'm going to be hosting a fireside chat with Wright Lassiter, CEO of Common Spirit Health. And then I'm going to turn over the stage to our very own Heather Cagle, managing editor of Punchbowl News, and she is going to host a panel conversation to close out the day. After, we'll have some more coffee, networking, food, and encourage you all to stick around after for some of that networking as well. As always, you can find Punchbowl News on all social media channels at Punchbowl News. We encourage you to share this conversation, get the word out there about what we're doing and talking about diving deep into policy issues like this today. And you might have heard we have a new YouTube show, Flyout Day, every Thursday, so encourage you to subscribe to our YouTube channel. Just search YouTube Punchbowl News, and you can just do a click, and you'll be the first to see it every Thursday night. With that, I'm going to welcome Senator Peter Walsh to the stage. Thank you so much. All right, Senator, thank you so much for joining us this morning.
Thank you.
All right, we are going to go deep on healthcare, but before we do, as all things Punchbowl News, we start with some news of the day, and Congress is always giving us a lot to work with, as we were talking about backstage. Government funding, it's the biggest topic we've been talking about now for weeks, but we are 21 days from a shutdown. Should Democrats accept a clean continuing resolution if it's short term and intended to allow for more time for a bipartisan funding deal, or are you against that?
Well, I'm totally for having us do our job, which is to pass a budget, and we don't do that. So it's all a question of what do we do in a very bad situation. I mean, this serious question, it is absolutely unconscionable that Congress won't pass a budget, and we can get into who did what and who's at fault. But the reality is it's very, very detrimental to the well-being of our country that we don't have annual budgets. And so I'm against that. I'm also against the shutdown. But on the other hand, what we're in right now is a rolling shutdown. When you have essentially the administration, now Russell Vought, doing pocket rescissions, then it really erodes the confidence that both sides need. So how we're going to come out of this remains to be seen, but I think all of us have to step back and take some responsibility for the failure of Congress to do its most basic job. And I think with the administration indicating that it is in favor of this pocket rescission, $5 billion, is a direct frontal assault on the power of Congress. Republicans and Democrats, by the way, had to have the power of spending.
So, okay, fundamentally, obviously, against, you want to have longer-term appropriations bills, not just kind of lurching from government shutdown to government shutdown. But would you support a short-term CR if it's intended for longer negotiations?
That's what we've typically been doing, so I would really pay some significant attention to what Senator Murray and Senator Collins have done. I have a lot of confidence in the two of them, so I know they're negotiating in good faith. So if they made a recommendation, I would be inclined to be supportive of that.
What do you think Democrats need to do? Because go back to March. If we rewind the tape, it was a funding debacle, right? Senate Minority Leader Chuck Schumer politically really got kind of kicked in the teeth over the fact that the Senate Democrats moved to support that shorter, funding bill. Do you have a clear strategy this time around? It feels like things are still coalescing.
You know, this is Punchbowl at its best, right? Trying to wrangle an answer to an unanswerable question and putting in the context of tactics. Here's the reality, okay? We have 47 votes in the Senate. So we can have whatever strategy we want to have.
Right.
But to be successful with any strategy, you have to have 51 votes or many times 60 votes. That's a reality. So much of what it is we have to do is try to make the case about why what is being done by the administration is worthy for us to oppose. And we have an enormous amount of legitimate pressure from folks we represent to stand up against the president. We're doing the best we can. What we can't guarantee is that we can win when we only have 47 votes. So a lot of our strategy is to fight, is to expose, is to reveal, is to lay out what the implications are. And obviously, the one big beautiful bill that we'll be talking about today is a case in point.
All right, we are going to shift, that's a great segue, our conversation to the topic of the day, healthcare, specifically focusing on patient access to care in rural communities, health systems, the impact that some of the policy changes have had in states like Vermont. So let's set the stage. You're from the state of Vermont. Talk a little bit about what you're hearing. We just spent August back in your home state. What are constituents saying to you, particularly when it comes to rural health care?
Well, people are absolutely terrified about what the implications are when this bill goes fully into effect. Let me just step back for a second. Healthcare is absolutely crucial for the well-being of all of us. Your family, your business, the taxpayers. We have to have it. And that's true whether you're in a red state or a blue state, whether you're Republican or Democrat. There's really three issues with healthcare, none of which are dealt with in the one big beautiful bill. One is the quality of healthcare. I actually think in our country we have pretty good healthcare, if you can get it. Two is access, and three is affordability. And our healthcare costs have been rising way faster than inflation, way faster than wages. And it's putting enormous pressure on everybody who's paying premiums, and it's putting enormous pressure on taxpayers with the Medicaid and Medicare programs. The access issue is made worse by the One Big Beautiful Bill, and the cost side is made worse by the One Big Beautiful Bill, and it really hammers rural areas. So let me get specific on it. In Vermont, 45,000 folks depend on Medicaid. I was checking on North Dakota.
My home state.
105,000 people. And in your state, 67% of the people who are in nursing homes, that's funded by Medicaid. Families who have a disabled child, Medicaid is absolutely the lifeline. And that's true in North Dakota, a Republican state. It's true in Vermont, a Democratic state. And the heartbreak for me in this discussion and debate about health care is that we get into this partisan battle about spending or about access, but we don't deal with a solution that's going to be good for folks in Heather's or Anna's North Dakota or Peter's Vermont. So this is brutal, and the hammer is coming down once these cuts go into place, because what happens in both states, all states, is once that person no longer has health care, 45,000 in my state, 105,000 in your state, they still have health care problems. And they show up at our rural hospitals. And our rural hospitals are all operating on the thinnest of margins. And those hospitals will open the doors when somebody comes in. They just won't get paid. And at a certain point, they can't stay in existence.
And then potentially that they can't stay open, right?
So rural America, that's exactly right. So rural America is in great jeopardy as a result of this. And you're going to see legislators who voted for this having to make a decision, because they're going to be hearing from their constituents, just like I am, what's happening to our local hospital. So this is extremely threatening to the well-being of rural health care and access to health care.
So I want to get into a little bit of kind of when that impact's going to be felt, because we've had conversations. We had a conversation last year on rural health, and I think a lot of health systems were already struggling, right? We're already trying to find ways to figure out how to pay the bills to make sure that they, whether they had to be part of bigger systems or figure that out. But when will the impact of this be felt? Is it already being felt, or is there preparation happening?
Yeah, there's two things. Number one, for the people who have Medicaid, that won't be, they won't feel that directly until after the next election. Funny that the timing was changed so that the cuts wouldn't actually happen until after the midterms. On the other hand, all the hospital administrators, and I guess you're going to have some folks from the hospitals here after, they're seeing over the horizon, and they're having to make adjustments already, and they're cutting in some cases in anticipation of the revenue decline that they're going to face. So you're going to see the pressure on the hospitals right away. Now, where there's going to be an immediate impact is on the affordable care subsidies, the Obamacare subsidies. That is going to be immediate and absolutely brutal. Let me give an example. In Vermont, if you're a family with an income of $110,000, family of four, and in Vermont that's a good income, but it's still, our expenses are really high, your premiums are going to go from $7,000 to $30,000. All hell is going to break loose when that happens. So that impact is going to be felt immediately.
Do you think that's something that Democrats should be using? We've been writing a ton about this over the last several weeks, right? That the healthcare insurance premiums are one of those big issues, are one of those areas where some Republican senators have also acknowledged concerns that this could be a big problem for them when it's November, it's December, and those rate notices go out. Is this something that you think will get included potentially in this government funding package?
Well, it should. I mean, we just can't do that to families, whether in North Dakota or in Vermont or even, in Texas. You just can't do that to them. And it's not the fault of the family that Congress and the whole medical establishment hasn't dealt with reforms that are necessary to reduce premium pressure. Those families got kids, they've got parents, they've got illnesses, and they've got to get access to health care. So, I think my Republican colleagues, they're dealing with the same thing I am, okay? So we put it in partisan terms a lot of times, but the universality of what the folks all of us represent have with respect to wanting to get health care when their family needs it is really, really urgent.
I want to go, because this is oftentimes, Punchbowl News is always very focused on what's happening in Congress on Capitol Hill. But you were the Vermont Senate Pro Tem. What insights can you share about that state-level budgeting when it comes to health care and some of the challenges when maybe what's happening at the federal level impacts these states so greatly?
Well, there was an article in the Times the other day about what the incredible burden will be on states. And the states, of course, have no fiscal capacity. All the states, Vermont, interestingly enough, is not in this category. We constitutionally have to balance their budget. So what you're going to see with all states, like take the One Big Beautiful Bill, the nutrition programs have been cut very, very significantly. And we'll lose thousands of families being able to get that $6 a day that makes a difference in their being able to feed. There'll be enormous pressure from my colleagues in Vermont for Vermont to fill the void. We have high taxes in Vermont already. We don't have the cash, all right? We have a drought right now. And we've seen discussions about getting FEMA out of any kind of rescue relief. We've had floods in Vermont. Vermonters want to come to the aid. We don't have the funds to be able to do that. So you're going to see over and over again, and healthcare is another example. We're very proud of the efforts we've made in Vermont with Medicaid expansion to make access to healthcare available to people. That is not unique to Vermont, okay? And this pressure will be immense on states, but Vermont has no fiscal capacity to be able to fill in for the huge hole that occurs when you cut nutrition benefits in healthcare like what's happening right now.
Is it a messaging problem? In some ways, each state has their own name for Medicaid expansion. The Badger State program, different programs that are happening across the states. So it doesn't, while they're going to be felt, at a state-by-state level, do you feel like Democrats have been able to adequately message when it comes to this challenge and what people can expect?
Well, who thinks the Democrats are doing anything good about messaging? All right.
Got a lot of honesty up here this morning. I appreciate that.
But having said that, this is much more than a messaging problem. This is like a real problem, okay? You're an employer. You care about your employees. One of the things you know they need is health care. You get employer-sponsored health care. You open the mail, you got a 20% increase. You've done everything you can for workplace safety. You've done everything you can maybe for on-site medical attention. You get a 20% increase. What do? You can't raise the prices, and you've got tariffs now to deal with, but you want to keep your employees. Well, what that means is you have a discussion about, do you want me to continue paying the premiums, or do you want to get a better raise? That's happening across America. So this is, it is messaging, but it's much deeper than that. And that's what frustrates me in Congress, because the challenges that we face are universal on the question of health care. It's not like it's a Republican type of problem or a Democratic problem. And traditionally what has happened, and I've seen this over and over again here, is the Democrats will primarily focus on access, and the Republicans will focus on cost. But their answer to cutting the cost of health care is to take away people's health care insurance, Medicaid, and even, by the way, Medicare is threatened if we have this kind of deficit. And the reality is, and this is something we did when I was in the Senate, when I was Senate President, we had a Republican governor. We had a big fight about health care, and Governor Douglas was arguing about cost. I was arguing about access, and finally we threw up our hands and said, hey, we're both right, and we came up with legislation that actually addressed some of his cost concerns that then allowed us to have more access. We are not in that place here yet, okay? And to the extent that we're always focusing on who's got the partisan edge on the messaging, we're not facing what the structural problems are that are beyond the control of individuals or even our community hospitals. They have a tight budget, but if they keep getting hammered, the higher prescription drug prices, higher medical device costs, then we're not able to give the services to the people that need it.
So let's shift gears a little bit. CMS Rural Health Fund. There's been a lot of discussion about whether that's going to be short term. Is the funding at the level that is actually needed to create the level of care? What's your take on the CMS Rural Health Fund?
It's totally absurd. Okay, you put in $50 billion, and that's all about walking around money for the Republicans whose votes were needed by the president, and you convince them that they're going home heroes because they've got this special fund, and you've just cut $1 trillion from Medicaid. So 50 billion, 1 trillion. So this is nothing but political. That's all it is. It was vote buying money. That's what it was. So we don't know how that money will be allocated, but what we do know is the hit financially to Medicaid is so much greater than that $50 billion, quote, fund. So that's magical thinking and political deception.
So, and it's short term, right? So, I mean, you look at what's happening with the Obamacare subsidies right now. I mean, they're going to have to probably go back to the well and find more funding, is what you're saying, right?
That's right. No, I am.
And how worried are you that a state like Vermont that isn't Republican is going to potentially have a problem with that? Like, being able to get access to those funds?
Oh, no, look, let's be real here. You have a special fund, half of it totally controlled by the president. How many, raise your hand, I'm not going to make you do that, but how many think that might end up in red states? Okay? Well, you're all right. So this actually is very frustrating to me, because talking about that $50 billion as a serious response to cutting health care by $1 trillion is just absolutely absurd. And, there's a tendency when we're on these tight votes, and of course this bill passed in the Senate by a single vote, and that was Vice President, right? And in those clinches, and you know this better than anybody because you guys are always checking who's getting what, and you're usually right, and somebody's getting something, and it's all about just getting to that 51st vote, in this case in the Senate. It's not about a structural remedy for a structural problem. So this is, in my view, bogus.
So we've identified, kind of where the problem lies, the struggle that rural health and rural hospitals and health systems are facing right now. It's September 9th. We have, a few months before the end of the year. Do you have any hope that there's going to be some relief that's going to come before then? Is there either in this government funding package, in an extenders package? What might that look like?
No, I do. On the Obamacare subsidies, I do, because I just gave you that example. Can you imagine being a family? You've got a teacher and you've got a firefighter, right? And they're making $100,000 or more, and their premium is going to go from $7,000 to $30,000. Okay, I mean, you can talk to Ted Cruz about that. He's going to be freaked out. You can talk to Peter Welch. I am freaked out, all right? And that's literally what is awaiting us. So that pressure is coming to bear. And you saw it with your interview with Speaker Johnson. They, quote, don't like the policy, but he acknowledged that they don't want to have that kind of disruption for families in Louisiana or families in Vermont. So I think the pressure on us to do something to shield folks against that kind of shock is great, and hopefully will allow us to come up with at least a short-term remedy.
I mean, Senator Majority Leader John Thune has said Democrats need to come up with a solution and bring it to them as part of this.
Well, that's the Washington blame game in advance, right? Anticipatory blame. The reality is we got a problem, and we've got to solve it. You know, the Obamacare has become very popular because it's made it possible for folks to afford access to health care. And, you know, I was in the House when we passed that, and then I was in the House when we tried to repeal it, like, 80 times. And the epithet was Obamacare, and now Obamacare is seen as a good thing. So whoever it is that, you know, did we cause the problem by giving America something that they desperately needed? Well, I'll take the blame for that. All right, I'm glad to have voted for Obamacare. But now we got to keep it because it's helping folks in South Dakota, in North Dakota, in Vermont, all around. I do believe, and I am a hawk on this, we have got to deal with the structural cost challenges in healthcare. And we should be working on that together. And I work with folks like Josh Hawley. I work with Senator Grassley on trying to deal with one element of that, and that's the incredibly high prescription drug prices that we pay. And this is an area, by the way, where President Trump has talked about most favored nation pricing. We shouldn't be suckers in the U.S. and pay 5-6 times for the same drug that in Canada or Great Britain or France folks there pay. I'm for doing that and other things that help bring down the cost of health care.
All right, we are going to quickly run out of time, but I want to get to a couple more things. And I want to zoom out a bit. I mean, we've kind of talked a lot about what's happening now in Congress, kind of the overall issues, but rural hospitals and providers are not only dealing with the current legislative landscape. I mean, if you look back over the last couple of years, I mean, there's been COVID, the opioid crisis, additional pressures that have impacted these hospitals that often are providing mental health, services, all kinds of services that even 10, 20 years ago were not on in their purview. What more can the federal government do? Are there policies that you think, it might not be before the end of the year, but in the next year or two that could be helpful?
Well, first of all, in the context of passing this one big beautiful bill and taking $1 trillion out, job one, repeal that. That is a disaster, and it's going to unfold quickly and accelerate. You just can't take that money out of the system without forcing hospitals to close and people to go without health care. So tinkering around here and there when what we've done is just taking a howitzer to the healthcare system, that thing's got to go. We ought to repeal it. That's my view. I don't see the piecemeal. On the opioid, by the way, this is the heartbreak for me. In the Energy and Commerce, when I was in the House, Diana DeGette and Fred, what was from Michigan?
Oh, Upton.
Yeah. Oh my God! Don't tell people I forgot his name because he's a really good friend. So we're going to keep that part on the down low, okay? But they worked together, and we got the Cures Act. And it was bipartisan, and it was bipartisan because all of us were horrified at the suffering from the opioid crisis that was afflicting our families and people in our community. And Upton and DeGette worked together and got this bill. And there was a lot of celebration, and rightly so, because it was about solving a problem that was affecting folks in all of our districts. We're seeing that funding diminish enormously. And for the last 3 years, the opioid numbers have been going in the right direction. And some of that was because there was bipartisan funding for treatment. That's getting taken away. And I'm really fearful as a result of that, you're going to see those opioid numbers going back up. So, this is, again, I'm repeating myself, but these challenges that we face in our country, the quality of education, the impact of social media on the mental health and well-being of our children, the
precarious state of healthcare in our community hospitals. They're so essential to the well-being of rural community life. Those are shared challenges, Republicans and Democrats. And it's not something we should be looking for, those of us in Congress, to get some, quote, partisan advantage of. We should be looking at those like Fred and Diana did, where they passed the Cures Act to solve a problem that helps your community and my community. So we're stuck in this sort of partisan battle back and forth, and we've got shared problems that all of us need to focus on. It's why I continue to try to seek in a very partisan world a bipartisan approach, because what I've experienced in politics is that enduring accomplishments have to ultimately be bipartisan.
So we're going to close on that because I think, you know, having some optimism is always important in a town where there's a lot of partisanship. But as you mentioned, I mean, kind of a couple times, this is not a liberal or a conservative state, right? I mean, especially when it comes to rural hospitals and rural health. I mean, this impacts people of all parties. Right. Are you having any productive conversations with colleagues on the other side? Is there some kind of a shining light or something that we can end on a high note here?
Yeah, I mean, when I talk to my colleagues, I'll talk to Senator Grassley or Senator Hawley, and I'll ask them, how are the community hospitals? When we have a conversation about that, it's a shared conversation because the problems we're facing in Vermont are similar to what they're facing, and I can do that with Senator Cruz. Then the system a little bit gets in our way, where we go into our corners and we have these big fights at the level of, we're going to shut government down or not. And obviously we should not be shutting government down, but we should be having some capacity to work together. And there's a lot of members in the Senate. And I have an immense amount of respect for my colleagues on both sides of the aisle in the Senate. There's some exceptions, but we'll keep that on the down low too. But
that's for later.
Yeah, that's for later. But the hope I have is that all of us who get elected do, by and large, feel better at the end of the day if we can say we've done something to help the people we represent. And what I've seen is that the people we represent, whether we're Republican or Democrat, have shared problems. Better education, housing, access to health care. So if we remember that, then it's going to give us allegiance to one another in that common effort to make an improved situation, as opposed to loyalty to a president of our party or loyalty to just our party, but the common goal that we have of helping our time here in Congress be productive to help the people we represent.
All right, Senator Welch, we are going to leave it there. Thank you so much for joining us this morning.
Thank
Really appreciate it.
Thank you.
All right, so we heard a lot. We covered a lot of ground with Senator Welch, and I have a lot of questions for you. But first, for anyone who is in the audience or certainly on our live stream that maybe doesn't know Common Spirit Health, give us kind of the lay of the land of how you fit into the healthcare system, rural health space.
Great. Thanks for having me here. It's wonderful to be here and talk about healthcare. Common Spirit Health is an organization that's relatively new. We were formed in February of 2019 with a merger of two of the largest Catholic healthcare systems in the country. So today we operate in 24 states. We operate nearly 160 hospitals in those states, along with a number of other assets. We pretty much do anything you could imagine in healthcare, from operating rural hospitals, critical access hospitals, large teaching academic facilities, suburban hospitals. We have about 2,500 other clinical sites in those states with physician offices, et cetera. And so we're one of the largest providers of Medicaid in the country. And so what you and your prior guest just finished talking about are quite important to us, certainly. And we're very focused on ensuring that everyone in every community we serve has access to high-quality health care.
Yeah, so obviously Senator Welch kind of talking about what's happening in Vermont, how he kind of sees the landscape for healthcare right now, but you're living this every day.
Yes.
I mean, across from rural to urban to, you know, teaching, I mean, Medicaid, all of kind of the areas. So I can't think of a better person to speak to about this, but Can you talk about the state of America's health systems and hospitals today? Are we in crisis?
Crisis is a great word. First and foremost, I'd say I'm really proud of what my colleagues at Common Spirit do. We have about 150 plus thousand employees who get up every morning trying to ensure that the communities they serve are healthier. And so I'm certainly proud of what our colleagues at Common Spirit and certainly our colleagues across healthcare do every day to ensure that Americans have access to great healthcare. Having said that, crisis is a great term when you think about the financial viability of the American healthcare system. You heard from the senator previously that his comment was he believes we have great quality in our healthcare system in the United States, and I'd say yes, we do. We have great quality at intervention. When you need your healthcare restored, your health restored, our healthcare system performs quite well. But we certainly know that we have challenges when it comes to access to primary care. We have challenges when it comes to access to appropriate mental health. And those problems are amplified in communities of color, in rural communities, in urban communities. Those problems are amplified. We know we have shortages of providers, both physicians. We know we have a nursing shortage. And we have a financing challenge. The senator talked about the concerns he has around rising costs of healthcare, around the rising costs of prescription drugs for everyday Americans. Those are very prevalent. We have challenges as it relates to insurance and insurance companies paying for services that their members get. And so from all those perspectives, we have a significant challenge. And then as we think about, I'm sure you might ask maybe a question about HR 1.
Yeah.
I can't call something beautiful that I don't consider beautiful. But as we think about that, that puts even more pressure on a system that is trying to recover from frankly what America considered a heroic effort during COVID, right? The American healthcare system responded incredibly well during COVID, incredibly well to a global pandemic. And as some stability around both the issues of provider resiliency and burnout, and the issues around the financial challenges related to COVID, as those things are trying to wane, we now are in the midst of yet another crisis.
So when you look at HR 1, the big beautiful bill, what is your biggest, and you go up to the Hill or you're talking to your colleagues, what's the biggest concern?
Well, I think, I would start at the highest level and say that the significant attack around the existing funding mechanisms for healthcare are the big concern. Yeah. And frankly, I run a very, very large healthcare system, and at times people think of an organization that has, nearly $40 billion of revenue as impervious to challenge, and we certainly are not, particularly when we serve so many patients who are either covered by governmental programs or who are not covered at all. So the first thing I would say is I'm concerned by the fact that HR 1 attempts to suggest that the way many states attempt to support raising reimbursement levels for healthcare through a process called the provider fee, the provider tax program, that HR 1 attempts to suggest that is somehow inappropriate financing. For us alone, it's nearly $1 billion of lost revenue. And when I apply that to across our network of facilities and communities across America, I get extremely concerned about its disproportionate impact in parts of our system, like rural healthcare. I'm concerned also by cuts to the disproportionate hospital program that again provides funding for those who cover larger percentages of the Medicaid population. We see a 9-figure loss of revenue on an annual basis related to that, and while most of the Medicaid things don't happen until 2027 and 2028, we believe the DSH cuts will begin starting this fiscal year, and again, that's real money for us. I'm certainly concerned about issues around loss of access to Medicaid enrollment, because what that will mean for us and for many of America's healthcare providers is those folks who today have some form of reimbursement will then go to having no form of reimbursement. And for all of us who are not-for-profit healthcare systems whose emergency departments are open 24/7, who accept patients without doing wallet biopsies, we don't turn you away.
Right.
I'm concerned about our levels of charity and bad debt rising at a disproportionate level that becomes unsustainable.
I was talking to a girlfriend who's in the health space, and she said, in DC, it's often the theoretical, but in your line of work, it is people coming into a hospital, coming into access for care, and you don't turn people away, right? I mean, so you talked a little bit about Medicaid cuts, the possibility of them. What, is that, and the revenue impacts that have in terms of balancing your books, but does that mean that you might have to see systems close or hospitals close? I mean, is that kind of how dire what we're talking about?
Well, I think the short answer is yes. There's a lot of rhetoric around hospitals make a lot of money. And, the short answer is not-for-profit hospitals, yes, there are some that are quite profitable. There are others that are not. And when you look at the trends of profitability in hospitals, it has been declining significantly. When you translate or relate that profitability factor to rural hospitals, what you find is that most lose money. So we operate 30 rural hospitals. I would tell you that almost half of them lose money. And so the notion that, well, because you're part of a large system, well, you just figure it out.
Resiliency,
Well, at some point, you don't just figure it out, because when 40+% of your facilities are not making money, you have to figure out, can you sustain those? We've certainly seen over the last years that we've had a couple that have closed because they've just become unsustainable. In some cases, they're unsustainable because you can't maintain the level of quality and safety of the facilities that you would like. You see in some cases the facility not closing, but services going away. And so in rural communities, for instance, where you have a need for maternal health care, oftentimes you can't keep OB programs going when you have funding declines, significant losses, and you don't have access to providers and or caregivers that are necessary.
So we talked with the senator about the $50 billion Rural Health Transformation Fund. Some Republicans have said that's going to ease the pain, made some rural state senators support the bill when they had some concerns. How do you view that fund? Is it a drop in the bucket? Is it going to be enough? Is it?
So I think we all in this room understand math relatively well, and I think the senator did a nice job of sort of saying $1 trillion on one hand and $50 billion on the other hand. Putting a finer point on it, yes, it's $50 billion over 10 years, so it's $10 billion a year. It's completely disproportionate in terms of the loss, and so I certainly wouldn't argue with someone saying, well, listen, it's $10 billion that potentially can go into rural health care. Absolutely, but it certainly doesn't make up for the losses, and it won't prevent rural hospitals that frankly may be either barely sustainable today or unsustainable and being carried by larger systems, having to make very difficult decisions that facility no longer is viable. And so the Rural Health Transformation Fund will not save America's rural hospitals.
So we have advocates here. We've got staffers certainly in the audience and on the live stream and others. What do you hope lawmakers will do when it comes to rural health? Is there something proactive, or is it figuring out a way to find more funding?
Well, certainly figuring out a way to find more funding is needed. I think that I'd love to say that if it's simple as the senator's comment of just repeal that bill, but I'm not expecting a repeal in the short term.
Yeah, That's tough to see.
It's tough to see that. When you think about the provider tax program, for us, 2/3 of the net revenues that we generate from our rural healthcare comes from provider taxes. 2/3 of it. So when those programs go away, and in some states, with what's happening in the bill, those provider fee programs become non-viable. And so in a number of places, we go from whatever the provider fee was to zero. When that happens in places where we have significant rural hospitals in our central region, we'll have to make very difficult decisions. So I'm hopeful that there will be some addressing around that. And then when you talk about other things like, funding telehealth and funding support for provider investments, those things are useful,
Yeah.
but they don't overcome the fact that you have rural hospitals that frankly become significantly negative in terms of their annual operations.
So we are quickly running out of time, but I often end these kinds of conversations with, I always like to ask, what's the one takeaway that you hope folks here will take away from our conversation this morning? Because we've covered a lot.
Yeah, well, I think the takeaway is fairly straightforward. First and foremost, we're in crisis. We need to develop solutions to the financing of America's healthcare. And frankly, that was true before H.R. 1, but H.R. 1 puts a extremely fine point on the fact that we will have a unsustainable financing mechanism for America's healthcare, and the work is not over. We need to find solutions that are creative, that hopefully are bipartisan, so irrespective of what administration's in power, we have lasting solutions for the financing of America's healthcare.
All right, we are going to leave it there. Right,
Thank you.
you so much
Appreciate
this morning.
it.
We really appreciate
Thank
it.
you.
I am thrilled to be moderating our last session and to be joined by 4 healthcare experts for a very lively conversation. I am joined by Robin Rudowitz of KFF, Emily Halubowicz of the American Heart Association, Dr. Tori Mack of the Children's Hospital Association, and Dr. Julie Yarrow of the ProMedica Charles and Virginia Hickman Hospital. Thank you all so much for being here today. We have a lot to cover, so I want to jump right in. We've heard a lot in recent months about the impact of congressional action here in Washington, not just the One Big Beautiful Bill, but also expiring Obamacare subsidies, potentially expiring Medicare telehealth services, things like that. Dr. Yarrow, I want to start with you. Hospitals have been dealing with significant issues in terms of access to care over the last several years. Recent legislative action is just compounding that. Can you just paint the landscape for us a little bit? What are the main issues when it comes to patient care for your health system?
So I'm over a 58-bed rural hospital in Michigan. I'm also an internist. Good old-fashioned dinosaur where I actually did private practice. I saw patients in the outpatient world, the inpatient world, and the long-term care, and those days are over. And that was the first hurdle. When we started to see a different delivery model and care transitions, we went from people doing a jack of all trades, which we need in rural hospitals. We need generalists. And our education system right now, we are seeing more and more specialists. So probably one of the biggest hurdles I saw in the beginning of my career was a lack of generalists. We need general surgeons, general cardiologists, general pulmonologists. And so what that has caused us to do is look at different ways to deliver care. Telehealth was one of them that you mentioned, that allows us to bring specialists inside our 4 walls, but it doesn't replace people. I have an aging population, so they come with multiple comorbid conditions. I also am in a rural area that I have a lack of resources. So my ability to transition care, to transfer somebody to a long-term care facility, home care, durable power of medical equipment, I have limited resources, which can really delay treatment, delay care. But probably our biggest impact, cost has been talked about. I don't need to repeat everything you just heard. I would echo everything about the finances. And being creative and thinking outside the box comes with cost, particularly when payers don't pay for that creativity. But again, in a rural health environment, we try to say it doesn't matter what your zip code is. We deliver the same high quality care that someone gets in an urban area. What we stabilize and transfer out, we do for all the right reasons. So we really need to look at healthcare about treating people. We all bleed the same color. It shouldn't just be about how we're going to pay for that healthcare, but what are the outcomes and what are the safety issues we need to address.
And Dr. Mack, I want to come to you next. I think you probably deal with a lot of the same issues that Dr. Yarrow touched on. But when it comes to caring for our youngest population, are there other issues or like workforce shortages what are the most pressing challenges that are unique to pediatric care, would you say?
Thank you so much. So Children's Hospital Association, we represent 220 children's hospitals across the country, and certainly they care for children in their hospital walls, but also regionally, nationally, their centers for referral. And so when we think about the unique challenges for our children's hospitals and for children in this country, I would think about it in terms of coverage, which we talked a lot about today. But specifically when we talk about kids, we're talking about 37 million children who depend on Medicaid, right? That's a large number. When we talk about rural, it's 41% of rural kids depend on Medicaid and CHIP for their coverage, which is really important when we think about sort of pediatrics. That's a really key distinction when we talk about that. I think the other pieces, of course, are capacity. So coverage, capacity, coordination. From a capacity standpoint, to your point about workforce shortages, right? We know they're prevalent. In contrast to the adult world, we actually see a lot of pediatric subspecialty sort of shortages. One example, I know the senator was talking about behavioral mental health. When we think about across the country, there are 15 child and adolescent psychiatrists per 100,000 kids in this country. That means when we think about communities, that's 72% of counties in the United States that don't have one at all. So these workforce shortages are really, really prevalent, and they impact care for sure. And the last piece in terms of a challenge is certainly that coordination piece. And so when I think about coordination, it's really about how hospitals work with all the places that children touch, whether that be schools, rural hospitals, and sort of how they all link and work together so that no family falls through the gaps.
It's interesting that you face some of the same challenges, but also different in terms of generalist and specialist. When I was preparing for this panel, I read that statistic that you had provided about child psychiatrists, and it was just astounding, you know? I want to turn to congressional action, what we've seen this year, what might be happening later this year. Robin, Dr. Mack touched on how many children are dependent on Medicaid for their health care, especially in rural areas. What are some of the real-world impacts from KFF's perspective of the One Big Beautiful Bill and other legislation that Congress is considering or that might be expiring?
Sure. So the bill included about $900 billion in reductions, federal spending reductions for the Medicaid program over the next 10 years. Congressional Budget Office estimates that there'll be 10 million more people uninsured as a result of the provisions in the bill. So these are major impacts in the overall healthcare system. So Medicaid, as we've heard, provides a huge complex role in the healthcare system. It's coverage for 1 in 5 people overall, 1 in 4 people in rural areas. It's 50% of births are financed by the Medicaid program in rural areas. It's the largest piece of financing for states. So states are really going to have to deal with some of and make very hard decisions about how to manage with less federal dollars. So I think the coverage impacts as well as the financing implications will have broad ramifications for states, providers, and for people who might lose access to coverage.
And I want to get to in just a minute some of the real world implications of having to make these decisions soon. But Emily, first, I want to bring you in here. Do you think that the public understands the impact, the potential of 10 million more people being uninsured over the next decade, the impact of these potential cuts, and how it could affect their health care and their access to care?
Well, thank you, Heather, and thanks for that great question. And just for a little bit of background, the American Heart Association, we're now in our 2nd century. We really sit at the nexus of medical research, quality care improvement, patient engagement, and advocacy. I lead our federal advocacy team in here in Washington, D.C., and for more than 40 years, we've been advocating at the federal, state, local level for enhanced and more affordable access to care. And so to answer your question, I would say yes and no. I think for the more than 100,000 advocates in our heart-powered grassroots network, They understand very acutely how important access to care is and how important Medicaid is to getting that affordable access. But I'm not sure that everyone, and especially here in Washington, always understand that what we're talking about are more than budget lines. These are lifelines. These are issues of life and death for many people in America. I would say, given the public engagement around the enactment of OB3, we saw our own advocates, thousands taking action. We saw tens of thousands of people in America taking action. I think many do understand what this means, but many unfortunately do not yet. They will certainly feel effects soon. Unfortunately, once these changes go into effect, it may be too late for a lot of individuals, and it may be too late for a lot of these healthcare institutions, especially in rural areas, who are going to be feeling the effects most.
Yeah, and I think we were talking a little bit about this behind the scenes before going on stage, but there's a ripple effect here for everyone's healthcare, right? Even if you are not one of the uninsured, the impacts of that will touch you too. Dr. Mack and then Dr. Yarrow, I want to go to both of you. Senator Welch, he said a lot of these cuts aren't immediately taking effect, but hospital administrators are seeing over the horizon and making adjustments now. Are you seeing that in your systems, and what does that look like? Dr. Mack, I'll start with you.
Yeah, absolutely. I think children's hospitals are always trying to fill in the gaps, been forced to be innovators from the beginning, and so are always forward-thinking and forward-looking in terms of what kind of solutions they can find. And they're looking for them, right, and sort of putting them into action. And particularly when we think about sort of rural communities and rural hospitals, the ways children's hospitals are sort of filling that gap in is helping to provide that care. And we think about some of our hospitals, which again are catchment areas. We'll take Intermountain Primary Care in Utah, right? They have a huge region, right? They're serving rural communities all the time, and they fill that gap with a lot of telehealth, right? And so how they are able to work with adult ER physicians who see children maybe more infrequently than they do, sort of equipping them with the training that they need, but then also the telehealth services to help them in real time. And so there are ways that certainly children's hospitals are thinking over the right horizon and trying to find solutions, but of course, a lot of that is not reimbursed, right? And so when we think about Medicaid and the need for reimbursement, it's key. Also thinking about those specialist providers and even the general pediatricians. Children's Hospital Graduate Medical Education, right, gets about half the funding of adult GME, and so it's really critical to think about how we're continuing to fund this, and then also incentives for pediatric providers to be in place. And so children's hospitals are certainly trying to fill that gap, but of course, need the funding and the scalability to be able to do so.
Right, right. And Dr. Yarrow, what's your experience with kind of looking over the horizon, as Senator Welch said?
So there's been many disruptors in healthcare, and I'll just point out hospitals keep their doors open. So when your disruptors close, the ripple effect is those patients come to our emergency rooms, and that affects everybody. It doesn't matter what your payer is. You will have longer waits. We will need more beds to transfer those patients out once we stabilize them. So we've been dealing with this for years. But I unfortunately have had this sad choice of closing a mental health unit because I didn't have providers. I didn't have the payer mix that I needed. Over 80% of my inpatients are governmental payers. That affects my bottom line. That inhibits me from keeping other services, as you heard, lose money, like labor and delivery and mental health open, so my community has access. And the great thing about healthcare right now is we don't practice healthcare like we did 20 years ago. Minutes make a difference. And so I need access to care because I can improve outcomes. I can save people, improve their quality of life after strokes, after heart attacks. That means I can get them back into your community, back working in your industries. So we really need to look at that access and how we deliver care and how we can improve outcomes. And so we've been dealing this with forever. Again, we use telehealth, we use robotic, we use ambient listening to decrease pajama time for our providers so they don't have burnouts. But there is a massive shortage out there of providers, greater than 1 million nurses predicted in under 10 years. I have a loss of respiratory therapists, pharmacists that I have job openings for greater than a year. So we need to not just look at the finances too, we need to look how we're going to build the next generation of healthcare and make those solutions that we can also get paid for.
And you talked a lot before we came on stage about governmental payers, and I know you've mentioned it a few times here. Can you elaborate just a little bit for those in the audience or maybe on the live stream who don't understand the importance of that and how those two work together, why that's so critical?
Yeah, so many rural hospitals have a higher governmental payer mix than many of our urban counterparts. So for my inpatient volume, I'm over 80% governmental payers, so that's a mix of your Medicare and Medicaid. I'm also a Medicare dependent hospital, which is always something up for discussion whether or not that will continue to stand. Losing those type of benefits can close more service lines in my region. I also, from an outpatient standpoint, I have a high Medicaid population. When you lose that funding, patients no longer come and seek care. Outcomes are poorer. People wait until their illness is to the point that I can't save them. Compliance goes down, readmission rates go up. So there's a story that goes beyond just receiving that initial payment. There's a story about how it affects that community and what solutions that we have to address that.
Thank you so much. I appreciate that. And I want to turn to the Rural Health Fund. We've touched on that a lot in our conversations this morning. Robin, I want to start with you. Senator Welch had some very colorful words. He said totally absurd, that it'll fill the gap, magical thinking, bogus. Mr. Lassiter said completely disproportionate, will not save America's rural hospitals. Do you agree with those assessments? And what would you like to add?
Well, I mean, I do think we've done some analysis at KFF, and when we look at the $900 billion in reductions in federal financing for Medicaid, we've done some estimates that translates to about $137 billion in reductions in Medicaid to rural areas. So, I mean, before there was the comparison of the $1 trillion, but we looked at the $137 billion that would be Medicaid reductions in rural areas. So clearly that is quite a bit larger than the fund, the $50 billion fund. I mean, in our analysis of the fund, I would echo some of the comments that were made that the fund is temporary, so it's time limited, whereas some of the reductions that are in place in the bill are much more permanent, built into the healthcare system. And there's many, many uncertainties about how that the dollars in those funds will be distributed across states and to hospitals, whether they'll all go to rural hospitals, whether they'll all go to rural areas. So I think there's a lot of question and uncertainty, and certainly the magnitude of the fund is much lower than the reductions.
And Emily, I want to bring you in here. Cardiovascular disease is still the #1 cause of death in America. I'm not sure if you had polled America, if they would know that, even though it has been for a long time. When you see these dramatic cuts to healthcare, particularly rural hospitals, how does that impact the treatment of cardiovascular disease, and how is your organization approaching these potential cuts and things like that?
It's a great question. Many Americans do know that. It is the leading cause of death here and around the world, but many do not, and that's part of what we do at the American Heart Association is raise awareness and help people understand their own risks. To your question about what this means for patients, frankly, it just makes it harder to get access to care. Certainly the cuts that we're expecting in Medicaid and the coverage losses in Medicaid are going to have a devastating effect, particularly for those in rural areas where we know based on data that rural residents are 30% higher risk for stroke, 40% higher risk for cardiovascular disease. But there's more imminently coming. You know, we have 2 cliffs that are approaching. We talked a little bit about the telehealth waivers that are expiring at the end of this month. Telehealth is healthcare. It is fully integrated into our healthcare delivery system, largely because of COVID. But I think the idea of taking that away and taking that access away would make it only harder. The other cliff, of course, is the premium tax credits that are expiring at the end of this calendar year. But really, the impact of that will be felt sooner as plans need to put out their rate notices before open enrollment. It's an area where we're really engaged with others in the patient community to ensure those are extended. Estimated 4 million people, according to CBO, will lose access to their care Just this morning, AARP released a report that nearly all of individuals in the marketplace, ages 50, 64, my age group, rely on those premium subsidies. This will have absolutely devastating effects, not just for those on the Affordable Care Act, but across the health system. Anyone who experiences insurance will see their premiums go up. And in fact, I think KFF's analysis said 75% increase anticipated if those premium tax credits expire. So all of this means less affordable care just means less access to care, and it will lead to worse health outcomes.
And I think you touch on a great point when it comes to the ACA subsidies, which is what we've seen. Democrats, and we've reported on this a lot at Punchbowl News, are trying to get the word out there that yes, these expire at the end of the year, but these premiums are going to increase far before then, and we really need to address this now in this government funding bill. That's the position that they're taking. I'm not sure how far that's resonating beyond Washington yet. You know, that's kind of part of the reporting that we're doing, but that is definitely, when you talk to them on the Hill, the message that they're trying to get out. Dr. Mack, I want to go to you. As Emily said, there are some telehealth provisions expiring at the end of this month. I was really interested in reading the notes before this panel about how critical telehealth is to pediatric care, especially in rural areas. How closely are you watching the action on the Hill, and what kind of impact would this have on the children that you treat?
A huge impact, and thank you for that question. I do want to touch upon quickly what she shared because I want that to be underscored too, just in terms of the allied health professionals, right? The respiratory therapists and the huge gap there, especially as we're entering respiratory season is huge. Children's hospitals, 2/3 of them are having trouble filling respiratory therapist positions, 40% don't have imaging techs, and that's really critical right now. So to your question specifically around telehealth, children's hospitals, of course, certainly during COVID, have used telehealth more and more, that have seen the benefits, particularly when we think about rural communities, right? There are really specific examples, not only of how they're used in hospitals, but even every place where children touch. So school-based health clinics, for instance, the ability to bring telehealth into school systems and be there with the parents and treat kids there, keeping them in school, right?
Yeah.
These are really important things, right? And this happened at Cone, Women and Children's Center in North Carolina. They were able to see 300 kids fairly quickly. 240 of them were able to stay in class. That's really impacting their well-being. So that is something that's critically important. But then also, those other 60 were able to be seen in the ER, right? And it's really important, especially as we think about the impacts, to your point, about people being sicker, certainly in rural communities. We see that in pediatrics as well. When they come to the emergency room, when they come to see their doctor, they're more ill, they have to travel further. And so the ways that we could think about sort of shrinking distance with telehealth is really critical.
Yeah, and you make a great point that being able to see patients via telehealth impacts other patients coming to the ER who need to be seen in person, right? And can be seen faster and quicker. Dr. Yara, I want to go to you on these issues. We've talked about the expiring Obamacare subsidies, the potential telehealth provisions that might expire. From your perspective and your health system, how alarmed are you by the inaction so far on the Hill, and what would be the impact for your hospital if some of these things weren't extended?
So I'll hit on the provider tax that was mentioned. So in my state, the provider tax has been instrumental in keeping services open. I think without it, one of our smaller hospitals would close another inpatient mental health. Again, a ripple effect. That means people are sitting in the ED for longer periods of time, not getting treated in crisis. It's really happening out there. Labor and delivery probably is another service line without provider tax dollars that we would see greater closures across America. 8 labor and delivery units in my state alone have closed recently. You know, the telehealth provision, again, it's not the end-all solution to healthcare and rural health. I'll just say that. Because you still need a provider on the other side of that monitor. So we still need people. There's also a lot of technology that we talk about that telehealth is phenomenal. We can give people monitors that they can put up to their heart and their lungs, and we can auscultate from 200 miles away. But that comes at a cost. And many of my patients in rural environment can't afford that technology or still have bandwidth issues. So again, we need those dollars to continue to be able to supply that innovation to those that need it, that are most crucial, that travel over mountains to get care, to travel. I'm 750 square miles. People have to travel over an hour just to get to me. If I cannot provide that care, they travel another 45 minutes to get that care. So this technology, this funding is making care accessible no matter what zip code you are. So if we lose that funding, I'm looking at what more I'm going to close. I'm looking at other innovative solutions, but chances are they're also going to come at a cost.
Right. Robin, I want to turn to you. KFF has done some polling on adults in rural areas, their concerns about access to care, things like that. I was hoping you could share some of the top line findings for this group and those on the live stream.
Yeah, I would say our polling shows that individuals in rural areas are already quite concerned about lack of access in terms of hospitals, behavioral health, being able to see a physician. And overall, I find always these statistics pretty staggering that over half of people in the country and in rural areas have some connection to the Medicaid program, so they themselves are covered, or they have a child, or have been covered at some point. And that statistic goes up to 2/3 of people when they know themselves or a close family friend. So the program has really wide reach and really broad favorability across political parties. So makes the impact of some of these changes very personal for people. And also staggering in some of our polling is that nearly all, 97%, which is a very high number for polling, say that the Medicaid program is important in their communities, and that's in rural communities also. So that means the reach of coverage as well as access to providers. So I do think to the point that many people are not feeling the implications of what is in the bill when they start to go into effect and people feel some of these implications. These are some of the base support and connection to the program, so many people will be affected.
Yeah, I mean, I was a little astounded by the numbers, just how many people say it is important. Obviously it is important, but not everyone always realizes, well, if I don't have something, is this important? But like you said, it touches so many people, particularly in rural areas. We only have a few minutes left, so we've talked a lot about the challenges. I want to turn to resilience. Emily, I want to start with you. There are several programs led by the American Heart Association to provide support, particularly in rural America. One that I was reading about in my notes before, the Rural Health Accelerator, which was just extended. Can you share more about that program and other things that the Heart Association is doing to try to provide support?
Sure, and thank you for asking. The Rural Health Accelerator, as you noted, was just extended to 2028. We started this in 2022, is really building off of our highly successful and impactful Get With The Guidelines program, which embeds in hospitals across the country, providing access to the best and most recent scientific evidence and measurement on how to improve the quality of care and care delivery. This program offers no-cost access to rural hospitals so they can access the best evidence and how to do their own improvement in quality delivery. And so we're really excited about it. It's one of the ways in which we support rural provider resilience. And on the topic of resilience, I just want to note, I think we would all acknowledge that rural communities and individuals are nothing if not resilient. I do think, though, and for years they've been doing more with less. As we look at the current environment and we look at OB3 and the potential Medicaid cuts, and none of these decisions or policy actions take place in a vacuum. If we're looking at the totality of actions at the federal level, be it OB3, or we're looking at discretionary spending cuts that affect medical research dollars that are going to institutions, when we look at cuts to state funding for public health and prevention, like smoking cessation, elimination of funding at the Office of Smoking Health, together with the rising cost of living, together with the provider workforce shortage and burnout, together with increased demand with an aging baby boomer population. At some point, you're doing less with less. And it feels like we're at a tipping point. Mr. Lassiter talked about a crisis level. It feels like we're there, especially as we look at now states who are kind of having to figure out how to fill all the gaps and the holes in all the funding cuts that they've seen. And so, yes, I believe our health system is resilient. I believe patients are resilient. But at some point, it feels like something has to give. And I think that's why the American Heart Association continues to advocate so relentlessly for policies that will improve people's health.
And I think you all have underscored in talking to Senator Welch earlier and Mr. Lassiter kind of the putting a face on the impact of action here in Washington, and the real world impact of that. I know we just have time for maybe one more question. I want to start with you, Dr. Yarrow, and kind of go down the line. Looking over the next 5 or so years, what gives you hope when it comes to healthcare and especially in rural areas and access?
It's the people I work with every day. It's the people I get to care for every day. We are resilient in rural healthcare. We wear multiple hats. That's not new to us. And hopefully we will persevere no matter what the changes are. I'm hopeful that we can start becoming more of the solution. We're doing a better job telling our story, letting others understand who we are, what barriers we have in front of us. But yeah, I would say it's the people, it's the willingness to be creative, flexible, innovative. That brings me hope.
Dr. Mack?
Absolutely. I'm fortunate enough to be able to work with children in children's hospitals, and so there's always hope in that. I'm a pediatrician by training, and I always find hope in our children. There certainly are the key to our future, as cliche as that might sound. And when I think about hope that our children's hospitals are really putting forward, is all of these solutions that they've found, right? We know things that work. We know what makes kids better. And so if we can build on those solutions, we can pay for them. When we think about sort of Medicaid, we think about reimbursement, we think about graduate medical education and incentives for our workforce. We know these things work. We just have to do them. So there's hope in that for me.
Emily?
I love this question because our vision is actually advancing health and hope for everyone everywhere. And I have so much hope as I see our incredible, courageous patient advocates who work tirelessly. It is not their day job, but to share their stories. It takes real courage to share these stories, and they give me hope, and it's what keeps me going every day.
Robin?
Yeah, it is a tough question, and I think that there are a lot of challenges ahead, but I would just echo, even being on this panel, the implications of the reductions hit states, providers, and people, and clearly on the provider side, it seems like providers are going to take the challenges head on. States, I know, are already working to face the challenges of implementation of many of the provisions in the bill, and certainly enrollees in the Medicaid program and people who need their health care coverage will continue to be resilient and hopefully meet the challenges as well.
I want to thank all of our panelists today for sharing their perspectives. A big thank you to Senator Welch for also joining us for the Summit Access to Care. We covered a lot of ground in all 3 sessions when it comes to rural hospitals and health systems. I also want to give a big thank you to the Coalition to Strengthen America's Healthcare for partnering with us to make events like this possible. I would love for everyone to stick around. We have more coffee, bites, and networking, and have a great day. Thank you all.